Hello and welcome back to today's session. Here we translate tricky topics into plain English. Today we are diving into the essential measurement of hematology, RBC size. Think of your red blood cells not as simple discs but as a massive fleet of identical delivery trucks. Their job is singular: deliver oxygen cargo. When something goes wrong with a factory, that is the bone marrow, where these trucks come out, so these trucks basically come out too small or too big. So if they are too small, we call it microcytosis, and too large, it's macrocytosis. The mean corpuscular volume is simply the quality control metric that tells us the average size of the truck. The pathology of anemia is determined entirely by why the factory got the size wrong. So, microcytosis, the small defective cases. When the MCV is low, it means the cell is small. This is fundamentally a hemoglobin synthesis problem. The cell won't stop dividing and maturing until it senses it has produced enough hemoglobin cargo. If it cannot make enough HB, it keeps dividing, resulting in many small cells. The problem is always the lack of components. We use a easy mnemonic, TICS, TICS, for the major microcytic differentials. So the T stands for thalassemia, the flawed blueprint. We have already decoded the thalassemia. So the factory has a genetic flaw in the blueprint for the globin. That is the protein frame of the truck. It keeps trying to build the frame but fails. So the RBCs look uniformly small, normal or low red cell distribution width, because the genetic defect is present in every single cell. And I stands for iron deficiency, that's the missing steel. This is the most common cause. We have decoded this too previously. The factory simply runs out of iron, the raw steel needed to build the heme component of the cargo. The RBCs are both microcytic and hypochromic. Crucially, the RDW is usually high, showing a mix of large normal cells and few new small cells. That's the defective fleet. And C here stands for chronic disease or inflammation. That's the trapped steel. The problem isn't the lack of steel, that's iron. It's the inflammation that locks the steel in the warehouse. That is our ferritin. Iron gets locked in the ferritin. The bone marrow factory cannot access it to build the trucks. So the iron stores, ferritin, are high, but serum iron and transferrin saturation are low. Finally, S stands for sideroblastic anemia, the defective assembly line. The factory has the steel, iron, but a defect in the specific enzyme assembly line that puts the iron into the heme ring. Iron builds up, visible as ring sideroblasts in the bone marrow. Macrocytosis, the giant immature trucks. When the MCV is high, the cells are too large. This is fundamentally a nuclear maturation problem. The problem is a defect in the cell's internal clock or blueprint, that's our DNA. The nucleus cannot divide fast enough, but the cytoplasm keeps growing. We split macrocytosis into two categories, megaloblastic and non-megaloblastic. So the megaloblastic one, it's the missing blueprint pages. So it's due to vitamin B12 or folate deficiency. B12 and folate are essential cofactors for DNA synthesis. Without them, the pages of DNA blueprint related to cell division are missing. The cell division delays, growing massive before finally splitting once, resulting in a large immature RBC. The classic finding is hypersegmented neutrophils. The nucleus of white blood cells also fail to divide correctly, often containing 5 or more lobes. This is the hallmark of a true DNA synthesis defect, which are hypersegmented neutrophils. The next class is non-megaloblastic macrocytosis. It's the damaged factory. Causes, it's due to alcohol abuse, liver disease, and hypothyroidism. Here the blueprint is fine, but the factory environment itself is toxic or compromised. Toxic as in alcohol and severe liver disease. They directly damage the RBC membrane or cause lipid changes, resulting in large, often round cells. Hypothyroidism may also lead to non-megaloblastic macrocytosis. So there are no hypersegmented neutrophils in non-megaloblastic macrocytosis and no DNA synthesis defect. The mechanism is usually membrane related or systematic. So, when faced with MCV abnormality, your clinical step is essential. Microcytosis or the iron studies, ferritin transferrin saturation to rule out iron deficiency and anemia of chronic disease. In case of macrocytosis, order B12 and folate levels and carefully review the blood film for hypersegmented neutrophils to confirm a megaloblastic cause. Understanding whether the factory's failure is due to the lack of components as in microcytosis or flaw in the maturation blueprint as in macrocytosis is the key to mastering the anemias. So we'll see you with another excellent analogy to induce the curiosity among the rotten brain of us, that is we medicos. Until then, see you.